dottoressa Mundy. La dottoressa Mundy è una pediatra che si occupa di malattie metaboliche, lavora all'Evelina Children Hospital di Londra e parlerà del progetto Glide. Non so se il traduttore è già pronto per la traduzione. C'è il traduttore? A questo punto i partecipanti dovrebbero posizionare la selezione della lingua dell'interprete sull'italiano e sentiranno la traduzione in italiano. Quindi cliccare sull'opzione mondo. Sì. Esatto, mondo italiano. Dovreste sentire la voce dell'interprete.
Thank you very much. I just want to check that you can all hear me.
Io sento perfettamente.
Yes, we can.
Perfect.
Sì.
Thank you.
Ok, ti sentono.
Perfect. So thank you very much for the invitation to speak to you all today. It's very nice to be with you virtually, although I would much prefer, obviously, to be with you in person in your beautiful city of Rome. So today I'm going to talk, so I'm just trying to get my slides to move on. Just one second. So today I'm going to talk to you a little bit about the history of the use of starches for glycogen storage diseases, how glycosade came to be, and the GLIDE trial, and the results that I'm able to share with you today. So before the use of uncooked corn flour for the treatment of glycogen storage diseases, the treatment was extremely laborious for families and the outcome was very poor, particularly for children with GSD type 1A. Fasting tolerance with good metabolic control, as measured by suppression of lactate for GSD type 1A and B, and suppression of ketosis for GSD type 0, 3, 6, and 9, could often be measured in a matter of a few short minutes for young children. In the 1980s, two studies, one in America and one in Europe, examined the use of raw starches to increase fasting tolerance. And I wanted to share some key factors from these studies. So this is the American study, and this is the European study. So firstly, one of the things you can see that in black is the effect of giving simple sugars glucose. Now what you can see is a very rapid hyperglycemia, followed very promptly by a crashing fall into severe hypoglycemia. And this is one of the reasons that we ask children and adults with glycogen storage disease to very much limit their simple sugars to avoid these rebound phenomenon. The other thing you can see in red is potato starch. And if we look at the European study and also at the American study, potato starch seems particularly poor at maintaining blood sugar. Both studies concluded that corn flour was the best raw starch to maintain blood sugar. And the European study even suggested that this could maintain blood sugar for 8 to 10 hours, allowing patients to sleep through the night. Now, this was quite groundbreaking work for patients with GSD, but if we look at the studies now, there are some criticisms of them. So in this first study, which was in one patient, you can see that the starting blood sugars varied very widely from 3 to above 6.5. And so was this really a fair comparison of the starches at that point? In the European study, you can see actually the patient started in a state of hypoglycemia at all times. And so there would have been counter-regulation and high lactate. So these levels would not have been maintaining in good control. So in the 1990s, Dr. Philip Lee, who was a great advocate for the treatment of patients with glycogen storage disease and for research in the UK and also further abroad in Europe, published on his findings in children at Great Ormond Street Hospital on the practical day-to-day use of corn flour and how long the fasting tolerance was. And he found that in children far from the 10 to 12 hours, that the median, if you kept the blood sugar at 4 millimoles per litre, which we would consider good metabolic control, the median was only 3.5 hours. So if that's the median, then some children would last considerably less time with corn flour. So in 2000, I joined Dr. Lee as a research student, and one of my studies was to try to identify a slowly digestible, palatable starch which had an improved fasting tolerance to uncooked corn flour. And how we did this is we had one very dedicated volunteer patient who agreed to undergo multiple starch loads until either our research period had come to an end or we had found a starch which could improve her fasting tolerance. And her fasting tolerance at that age, at 21, was 6 hours on corn flour. So we had a variety of different ideas at how we were going to approach this. First of all, we thought we would go back to basics and look at the raw starches. And our patient was very dedicated, and for the 24 hours before each study had exactly the same routine and ate the same food. So we were very fortunate that we could get good comparative data and started with the same glucose and lactate within 1.5 millimoles for each study. We then had some ideas about trying to slow absorption of the starch by decreasing gastric emptying, and that was uses of pectin, which is a polysaccharide, different types of fats, and alginate and guar gum, just to slow that absorption. We then felt that potentially what was happening was that the absorption was too slow, and so we tried a number of different modifications of some mixtures of very fast acting starches and slow acting starches in different ratios. And by this point, we had perhaps tried 30 to 40 different starches. We were working with a university department in Glasgow, who were a carbohydrate department. And we had almost got to the point where we thought we were going to give up. And then we tried some different modifications, in particular on one particular starch. So just to remind people, plant starches are a mixture of amylose and amylopectin. So amylose is long, straight sugars linked together in straight lines, where amylopectin is a branched form of starch. Generally speaking, the higher the amylopectin content of the starch, the more resistant to digestion. Now, in the early half of last century, the Reverend Farnham in China made some observations on an unusual type of corn that he called waxy corn. Now, this corn has its own inborn error of metabolism. It has a naturally occurring genetic alteration, which leads to a decrease in the synthesis of amylopectin. So if you look at the little chart we have there, you can see that
no, ho detto di lì, io continuo ad andare lì, ma non si muove.
The amount of amylopectin in this waxy maize starch is much higher than uncooked corn starch. And this leads to an increase in the resistance of the starch and to a decrease in the GI unit. So for the GI unit, if you have a pure glucose, you will have a GI unit of 100. And you can see the comparison between the waxy maize starch and uncooked corn starch. We also applied some physical modifications using heat and moisture to arrive at our finished product. And the last starch we actually had a chance to try with this patient, we found that at 6 hours, which was the moment when she always lost control, we had good metabolic control. I've just shown the lactate here to show that the control was much better, and this persisted out. So at this point, I handed on the research to Dr. Bhattacharya, who's now a consultant in Sydney in Australia, and he ran a small study to see whether we could replicate these findings in a small group of patients, which he did. The starch was then taken on by Vitaflow, who were able to produce it in a commercially available preparation. And because WMHM20 is a bit of a mouthful, it was relabeled as Glycosade. So we come to the Glycosade trial, which is an international multi-center randomized trial that compares Glycosade and uncooked cornstarch for the dietary management. So you might say, well, why are we only now reporting on the GLIDE study? Glycosade has been available for many years for different patients. And it was, but when we came together as investigators to consider the GLIDE trial, we found that really there'd only been a small number of patients with GSD type 1 and 3 who had been evaluated. The two published studies were quite different. The first study was a daytime starch loading study based on body weight. And the second study was a nighttime study with a single dose of uncooked corn flour Glycosade only in adults. There was also extremely limited data in children and no data on ongoing use. So we wanted a trial that looked at more than just GSD type 1 and 3. We wanted some data on children. And we really also wanted to know that what happened to people once they had been on glycosade or uncooked cornstarch in terms of their growth, in terms of the overall dietary quality, and also the quality of life, something that was very important for our families. So these are the centres that took part. There are so 1 in America, 3 in Europe, and 3 in the UK, as alas, we are no longer part of Europe. So we wanted to include anybody we could. We needed patients to be at least 2 years of age and been on an intake of uncooked cornstarch or glycosade for at least 6 months. And the reason was we were going to look at long-term outcome data. There was some evidence that below 2 years of age, the absorption of starches can be rather variable. And we didn't want any changes we saw to be just because a patient had just begun a starch. And we didn't want to exclude patients. So really the only reason we excluded women who are pregnant or breastfeeding was not because there's any problem using uncooked corn flour or glycosade for these patients. It's perfectly safe. But it was because we were going to look at anthropometry. And so obviously pregnant and breastfeeding women would have a very large change in body shape, which has nothing to do with the starch they were receiving. So this was a 2-part study, and the first part was a randomized double-blind crossover comparing the starches. And the reason we did this at the beginning, not just randomly allocated starches, was that both starches were prescribable in many countries. And this is a 2-year study. So if one starch showed a great benefit for a patient, particularly in a child, we did not want to deny that patient that starch for a 2-year period. So the first part of the study really aimed to identify, was there a better starch for an individual patient? And the second part, the part in some ways I'm most interested in, is the follow-up study, where we look at changes in the patient over 2 years on each starch. So although I'm in some ways much more interested in the long-term data, that's data that we haven't really tested and we don't know what the changes will be at all. So when we discussed with the study statistician, they felt that the primary outcome measures should be around the quantitative data we received in the first part of the study. So for GSD type 1, we were looking to see whether there was an impact on the duration of normal blood sugars. However, for GSD 3, 6 and 9, what we often find, particularly as patients get older, is that they can maintain their blood sugar in a normal range for a very long time, but at the expense of metabolic control and the development of ketosis. Now, just to point out that we wouldn't advocate that the BOHB, which is the beta hydroxybutyrate or ketone that we measure, is ever left in a patient to get above 1 or indeed above 0.4. However, we wanted a chance of showing whether these starches behave differently over time. So this was an outcome measure, not what we would consider a treatment goal. So the study has taken quite some time. There have been some challenges. So we enrolled the first patient in February 2016. The American Center moved from Florida to Connecticut and ultimately, as I think many of you will know, closed just before the end of the study. We had COVID in the middle, but now I'm pleased to say that all patients have had their full study and the full 24-month follow-up, including all the American patients. The data has been entered and locked, and we're in the process of analyzing the long-term data. So it's the interim data which we have analyzed that I'm going to share with you. So what's the methodology for the starch loads? Well, a patient was randomized either to receive glycosade or uncooked cornstarch. The uncooked cornstarch we used was the same across the study, whatever a patient was normally on, and we used Argo. We dosed the study a little bit differently to previous studies. Because some patients have an increased BMI, we decided to use the ideal height weight. So that's the weight based on how tall you are. And also that if you look at glycosade and uncooked cornstarch as products, glycosade has a little bit less carbohydrate content. And so we based the loads on the carbohydrate content. So there would have been a slightly difference in weight. We used a big black beaker to mix up the starch so we could try and blind as much as possible. But patients who've taken one product for many years are very professional. They understand and know which starch they're taking. But we asked them not to speculate during the study with the study personnel. And the personnel who were analysing the results were not present during the starch loads. We then had a washout period of 2 to 6 weeks, and the patient received the alternative starch. And then the clinical team sat together to decide which they felt was the better starch for the patient. This is just to show how we recruited across the different sites, and it's quite even if you compare countries, if you compare America, Europe and the UK. There were a few extra men in the study, and that's probably because we included GSD type 9, and therefore there are more males with GSD type 9. And there are a few more children. Again, the centres were actively wanting to recruit children as there was very limited data for these children. And also, often for a child, there is more to benefit, they feel, because of their very short fasting tolerance. So if we look along the different types, we managed to get very good recruitment in type 1A for adults and children, and very good recruitment in type 9 for children, and in type 3. We got very poor recruitment for 1B, and type 6 is really quite a rare disorder, and therefore recruitment wasn't particularly good. So if we speculate on why we had the recruitment spread we did between adults and children, I think more adults who have very short fasting tolerance, which is often type 1A, were attracted to the study and were keener to take part. And if we look at the age range of the patients, you can see where we did struggle was in the very young children. And I think this reflects part of the problem with the beginning of the study, which is that it required 2 fasting challenges, which requires cannulation. These patients are often incredibly difficult to cannulate, and the cannula has to be working appropriately that we can sample through it. So many patients and many doctors felt that it was unfair to invite some of these younger children to take part in the study if they were known to have a difficulty in cannulation. But we did manage to recruit good numbers amongst the 6 to 17 age, which is one of our target recruitments. So once we had finished the second starch load test, the clinicians decided which was clinically the better starch. However, before they went on with the starch, they involved a discussion with the patient or the family. And that was because we were going to ask a family or a patient to go on with the starch for 2 years. And many of these patients will be taking their starch orally. And if they felt they really could not take the starch that they had tested better on, then it would not be fair to try and insist that that was the starch they continued for 2 years. As it was, we had very little change. Most patients and families were very happy to continue with the starch they found to be best. So I think in many ways, this is the key slide. And after this, we just have to try and understand, well, what was it about the starches that led to this result? So we had a highly significant clinical decision that glycosade provided an increased fasting tolerance or a better profile for patients. This was more marked in the ketotic groups, but was still present very strongly in the patients with glycogen storage disease type 1. So the rest of the slides, I'm just going to try and unpick why did clinicians come to that conclusion. But just to explain, first of all, for any family members who are not particularly used to seeing these graphs, this is a Kaplan-Meier survival chart. And in this time, surviving means that you are not hypoglycemic. So patients, we don't have complete data across the whole 12 hours for each patient, because if you're a small child with GSD, you probably only lasted a few hours. So this is a standard way of comparing data when you know that patients will not be able to provide data at every single time point. The 2 colored lines indicate the 2 products, and at the beginning, because no patient will be allowed to start the study hypoglycemic, the lines will be together, and if we carried on to 24 hours, eventually the lines will come completely together. So what we're looking for in these sorts of curves is there a separation at any point between the green and the blue lines? If there's a separation, it may well be that these products are behaving clinically in a different way. If the lines crisscross randomly over each other, it is suggestive that there is no particular difference in the products. Now, I said that this particular graph I'm showing you isn't a primary outcome measure, and the reason it isn't is because we thought that patients with the ketotic forms, we would fail to show a difference because of the ability to maintain normal glycemia. However, we were wrong in that actually you could see, even when you included all patients, that there was a difference. Now, to explain what the proportional hazards ratio is, whilst we can look at the graph and consider there may be a difference, we do need to find some way to understand whether that is statistically significant or not. So when we look at the hazards ratio, we are comparing glycosade to uncooked cornstarch. If the products are are identical, we would expect a hazards ratio of 1. If the ratio is less than 1, it favours glycosade, and if it's over 1, it favours uncooked corn flour. And the p-value gives you some idea of how significant the findings are. Now, what you can see as well, when we look at the median times that patients hadn't reached an endpoint, is that there are some patients on glycosade and uncooked cornstarch who could maintain their blood sugar even at 12 hours. And for those patients, we're not able to separate them. So then we start to look down at some of our primary outcomes. And for this one, this is looking at patients with GSD type 1 and a similar picture. Now, the thing you can see here is that the greater separation between the two lines occurs a bit earlier, between the 4 to the sort of the 8-hour mark. And then right at the end, there's a small separation. When we look at this, we find, however, that it was still a significant benefit to glycosade, even though visually it doesn't look so good, which is why that we do need to apply a robust statistical methodology. But then when we look at the median time of survival, you can see that only 25% of patients were surviving out to 7.5 hours with glycosade. And you can see that, therefore, the reason that the starch is working better is it's working better before these time frames for patients with GSD type 1. So they're gaining more benefit earlier in the study rather than right towards the end of the study. Now, this is a way of looking at figures when you have a change in baseline. It's a geometric mean. And we look at this when we're not so interested in any particular measurement at any particular time point. We're interested in the overall pattern. So again, what we're looking to see, do these lines crisscross? But they don't. They remain separate at all times. And therefore, we feel that glycosade in these studies, starch load studies, gave a better suppression of lactate. We look at the same for the ketotic GSD types. Now, these look, when you look towards the end of the study, that there was a beginning of a separation, but many patients survived to the study and beyond. And so when we look at this, although there is a trend to favouring glycosade, it isn't statistically significant. And that is because for many of the adult patients with GSD type 9, if you gave a load of glycosade and uncooked cornstarch, they could maintain their blood sugar to 12 hours, which is what we expected. So then we looked at ketosis. And again, this is where we start to be interested more towards the end of the study. And here we find that there was a statistically significant effect for glycosade, and that it was favouring the suppression of ketosis for longer towards the end of the study. And it may be that for these patients, it would have been better to go on beyond 12 hours. However, most patients really don't need a starch that lasts longer than 12 hours. So we didn't feel that it was a clinically relevant to go on to 14, 16 to show that there was a further separation. And again, this is the same type of curve. It's the geometric mean looking at the ketone response, beta-hydroxybutyrate. And again, you can see, particularly at the beginning of the study, unsurprisingly, the ketones are well suppressed both by corn flour and by glycosade with a load of starch. But towards the end of the study, where we're more interested, there begins to be a widening separation of the two curves. We also wanted to understand, however, whether the starches were acceptable because one of our things could we make a palatable starch? So we did ask for people's experiences whilst taking the actual starch load. And actually most people, even though it's quite a large starch load, so it was 2 grams per kilogram of ideal height weight. So it's quite a large load for some patients. So most patients didn't really find too many symptoms from that particular starch for either of the loads. Most people said it was fine. However, there is a separation when it comes to how people found the taste and the mouthfeel. Now, actually, quite a lot of people were some people were very positive, and some people were in the main neutral about either. And one of the things we haven't gone to do yet is that if you're on one particular starch for some time, over many years, often patients come to a point, as with any other metabolic product, where they prefer that because they're used to it. So we haven't drilled down into this data to try and understand, do the patients who prefer one or the other, were they already on one of these products? But we did feel that there was an issue in mouthfeel and taste for patients with glycosade, and this was something that reflected our own thoughts in clinical practice. So where are we going now? Well, the trial has now completed, as I said, and all data is entered, and we're beginning the statistical analysis of the long-term data, which is in many ways a lot more difficult. I have to say there has been delays because the team have been less able to meet together because of COVID. However, in the short-term analysis, we did find that glycosade did provide a statistically significant improvement in the metabolic profile in the starch loads. Obviously, that's not the same as real life. And it's the longer-term benefit, the starches we look to be judging. So what were the problems? Well, we really didn't have any good data on GSD type 1b. Now, actually, I'm not very upset by that now, because I think that study would have become almost worthless given the introduction of empagliflozin. So I'm not sure how many patients in Italy are taking this. All my patients now with 1B are taking this medicine, and it has been a totally dramatic response for those patients. I'm extremely pleased with the outcome and their ability to tolerate any starch, and signs that the inflammation in the intestines is reduced. So I think in many ways we will be better off now looking at the starches with patients who are taking empagliflozin, and that the previous data would not maybe have been very helpful. We do have recruitment difficulties for the very young, and I'm not sure if we will be able to get around that. I think we'd have to have a different type of study which did not include the starch loads at the beginning. We need to think about the short-term and the long-term benefits and how acceptable, and whether many patients drop out from either starch load. Because of this data, I think, as you may know, VitaFlow did go on from this data to produce a new product which is available, which has a different mouthfeel and a sort of more lemony taste. And we can see whether this improves acceptability within our patient group. Obviously, sometimes, and I think it tastes better, but I don't have to take large quantities of it, so it's not really important what my feeling about it is, it's what patients feel about it. And then we do have to think about the cost implications. Now, I hope that this study will give some benefit to countries where they have to provide some evidence to insurance companies about benefits of one product versus the other. We're lucky in the UK that we are able to freely prescribe either product, but obviously we are a national health service. I do have to think about not spending money that could be spent on something else, and glycosade is much more expensive than uncooked corn flour. So when we speak to people, they often say, well, what would constitute making this worth the money? And I find that really very difficult, because it is very different depending on where you are across your journey with glycogen storage disease. So if you're an adult who maybe can last 6 to 8 hours, actually a really significant benefit is able to sleep undisturbed throughout the night, without a doubt. And you may require an extra 4 to 6 hours to do that. However, if you are one of our infants or small children with GSD type 1, and this was not so much with our starch, but with empagliflozin, we have, according to the family, revolutionized their life by increasing their time with fasting tolerance to 2 hours from 90 minutes. They feel that 2 hours allows them to have a significant better quality of life and to enable their child to take part in so many more activities and to go to nursery safely, whereas 90 minutes was a real drain on the child's quality of life. Now, obviously, so 30 minutes of them, incredibly important. 30 minutes for an adult with GSD type 9, not so important. And then if you're a school-age child, probably the benefit you need is so that your parent can give you breakfast in the morning and your starch, and be very confident that till lunchtime that you will have, you will be safe. So I'd like to acknowledge all the patients, particularly the patient right at the beginning who was so giving of her time. The Drummond Trust was a small charitable trust that funded all that research at the beginning. It wasn't industry funded. And Ulrike Stuyveld was the independent expert who oversaw the safety of the study. And these are the chief investigators of all the different study sites. So thank you very much. And if you have questions, when they're translated, I will be happy to